Today we will be discussing the Chedoke-McMaster stroke assessment. Participation in a training course is required for administration of this assessment. There are specific portions for OTs to score and for PTs to score, which we will specify later on.
The Chedoke-McMaster stroke assessment measures motor performance and falls under the categories of body function and activity in the ICF. It is used on clients ages 18 to 90 and those who have suffered a stroke or an acquired brain injury. The CMSA is an observational test that takes 45 to 60 minutes. It is recommended that you do this test over 2 consecutive days because of the client's typical lack of endurance and concentration. The purpose of this test is to classify clients in terms of clinical characteristics and stages of motor recovery. In addition, it can be used to predict rehab outcomes and measure clinically important change in physical function. It is recommended that the testing environment keeps distractions to a minimum. Clients should wear comfortable clothing that exposes the knees, legs, and shoulder. Access to the stairs and outdoors are needed.
There is multiple equipment needed for this assessment. It should be noted that all equipment should be set up ahead of time. The equipment includes an adjustable table, a pitcher with water, a measuring cup, a ball 2.5 inches in diameter, such as a tennis ball, a 2-meter line marked on the floor, and a stopwatch. So are you experiencing any shoulder pain today?
No, I'm not.
So we are about to begin our assessment. First, we're going to look at postural control. So I'm going to have you take off your shoes and any socks you may have on, if you don't mind, and we will make our way over. So first, I'm going to have you stand up. Perfect. And now I'm going to have you take a step forward, first on your weak leg and then on your strong leg. Thank you. And now, standing just on your weak leg, I'm going to ask you to hold it for as long as you can. Alright, you can stop. Thank you. Yep. And now I'm going to have you walk on your toes the whole line. Now we're going to look at your arm. So your right arm is your affected arm, correct?
Yes.
Okay. So I'm going to have you take that affected arm and reach out and touch your opposite knee. Thank you. Alright. So now I'm going to have you straighten out your elbow and lift your arm up to shoulder height. And then can I have you put your arm back up into that shoulder height and a little bit lower, thank you. And can I have you turn your palm up and turn your palm down? Perfect. And then can I have you raise your arm up with your palm facing up, all the way up. And then come back down with your palm facing down. Thank you. Alright, so next I'm going to have you clap your hands above your head and then behind your back. And I'm going to have you do that as quickly as possible. Okay. Alright, I'll tell you when you can begin. And go ahead. So now we're going to move on to the activity inventory. So the first thing I'm going to have you do is from this position, go on your side to your strong side. Thank you. You can roll back. And now I'm going to have you do the same thing down to your weak side. Reach out and go back. And then so we're going to actually get you back up on your weak side. And then I'm going to have you go into sitting from there. So now we're going to look at your hand. So the first thing I'm going to ask you to do is make a fist, just like this. Perfect. And now I would have you hold your hand out like this, and can you just grab the paper using your thumb? Perfect. And can you touch your little finger to the tip of your thumb? Great. And then can I have you go like this, and then can you just bend your index finger without moving anything else? Great. And then now I'm gonna give you these. So this pitcher of water and pour it into this measuring cup. And then once you do that, I'm gonna have you take the measuring cup, but with this time, on the way back, I'm gonna have you turn your palm up to pour it in.
Okay.
Great job.
There are two indexes that are being tested in the Chedoke-McMaster stroke assessment. First is the impairment index that determines presence and severity of common physical impairments. OT looks at shoulder pain, postural control, the arm, and the hand. A 7-point scale is used here and corresponds with the 7 stages of motor recovery. There is a max score of 42 in this inventory. The next is the activity index. This measures the clinically important changes in the client's functional ability. Max score is 100. The activity inventory is divided into gross motor and a walking index. There are 10 categories in the gross motor, and OT only does the first 8. The max score is 70. The walking index is done by a PT and has a max score of 30.
For the scoring of this assessment, there is a portion that we do not do. It is filled out by the PTs, and you would gather the information from them after they have done the assessment. The first thing you would do is ask the client if they are experiencing any shoulder pain. If they have no shoulder pain, they are a score of a 7. If they report any sort of pain, you would look at the lower levels to see if they correspond with any of those. Next, you would look at postural control. Above each section tells you which stage to begin at. For postural control, you begin at stage 4. In order to continue on to stage 5, the individual must be able to do 2 of the 3 items. If they are only able to do 1, you would go back to stage 3 and see if they are able to do those, and so on. If they only were able to do 1 of the tasks on stage 4, but they were able to complete all 3 on stage 3, then their scoring would be a 3. Next, you will look at the arm and the hand. For both of these sections, you start at stage 3. If they are able to complete at least 2 of the tasks in stage 3, you move on, as before. The last part of the assessment is the activity inventory. This scoring can normally be done at the same time as the impairment inventory, but for the sake of this video, we have done it separately. The scoring works a little differently here, with the scoring levels being based on what the client was able to do independently. Questions 9 through 15 are done by the PTs, including the walking aid. You would receive the score from the PTs later on.
These are the psychometrics for the CMSA. There is no normative data for this assessment. All of the reliabilities and validities are based off of acute strokes. The test-retest reliability is excellent in the impairment scale. The inter-rater reliability is excellent in both the impairment and activity inventories. The intra-rater reliability is excellent as well in the impairment scale. Internal consistency is also excellent. As for validity, there's excellent concurrent validity with the FMA, the FIM, the Barthel in certain domains. There's also poor concurrent validity with the Barthel in shoulder pain, eating, and bowel incontinence. Construct validity is also excellent.
More of the psychometrics include the MCID. The MCID via caregivers is a 7. The MCID via stroke patients is an 8. There are multiple biases for this assessment. This includes the language. It is only available in English and Canadian French. Another bias is that the current version has not been studied to determine its ability to predict functional outcomes earlier than 3 weeks after having a stroke. The limitations include that it cannot be used on clients who suffered a stroke less than a week ago. As we learned in class, Brunstrom is not a form of effective evaluation, yet this assessment uses an aspect of it, so using Brunstrom as a descriptive factor is a limitation. Predictive validity of the current version has not been examined, which is also a limitation. Here are our references. Hope you guys enjoyed the video.